It's my pleasure to introduce Joe Maguire to you. And Joe's going to talk to you about this thing that so many of you have been asking about over the last several months. Joe, thank you.
Sandy, thank you. It's an incredible turnout. I'd like to thank Sandy and Lee. And every morning when I'm shaving, I get up and I'm very excited for work. And at Wills Eye Hospital, you've heard Dr. Ho and Dr. Regillo and Dr. Garg and Dr. Kaiser speak, and they're all my partners at Wills Eye and Mid-Atlantic Retina, and they do incredible work, and they're really fun to be with. Emily, I just saw walking up here, and she's a gem as well. Solid people who do solid work and solid research, and it's a lot of fun. And the end result is that, can you hear me now? The end result is to our patients' benefit, and there really has been a sea change in the development of treatments for macular degeneration in the last 5 years. Very, very different. So what have you learned this morning? One, you've learned that macular degeneration is the #1 cause of central visual loss in this country by far. Add diabetes and glaucoma, which are 2 or 3 together, they don't approach the number of patients who are afflicted with central visual loss from macular degeneration. What else have you learned? You learned that the eye is like a camera. The retina in the eye is the film in the camera, and the macula is not a disease, it's a location. And although it's only about 5 to 7% of the surface area of the retina, it's like your thumb on your hand. If you lose it, you lose 90% of the function of your hand. Central visual loss, legal blindness. What else have you learned? You've learned about active treatments and diagnostics in looking at macular degeneration and its treatment. Anti-VEGF injections, steroid injections, laser, photodynamic therapy historically. You've learned about future treatments, what's on the horizon. But what if you're one of the 500,000 people in this country right now who have bilateral central visual loss from end-stage disease? What can you do for you? The future is 5, 10 years from now. And effective treatment for active disease is not in your purview. It's not there. So what are your options? And your options are essentially low vision support. And low vision support, as many as you may know, uses 2 principles: magnification and good contrast or enhanced lighting to magnify and make things larger so that the retina that is functioning closest to the center can pick up larger images. And that's why sometimes my patients will tell me that folks will ask them why they're looking askance when they're talking to folks. And the reason is, intuitively, we learn how to use our near peripheral vision. We're very adaptable. Well, what kind of tools do we have? Low vision aids. The greatest development, I think, when I was growing up, a 19-inch TV was huge, okay? And it wasn't HD. Now you can go to the department store and get a 56-inch TV with HD, and I have kids with albinism who do their homework on it by putting print up on the TV, one of the good uses of TV. And that's been a boon. But you can't carry around an HD TV. You can use low vision support in the form of glasses or viewers where you slide text under. But again, difficult when the eye moves. If you're off center, anybody who has ever had what we call aphakic spectacles from the old days of cataract surgery, if you get off center, everything is distorted and warped. From a physics standpoint, the closer that a lens gets to the eye, the more utility you get out of it, the more benefit. And anybody who's worn contact lenses and distance spectacles knows that. The contact lens gives you better vision. If you put the lens inside the eye, the mechanical advantage optically in physics of that lens goes up even greater. So what is the intraocular miniature telescope, IMT? Essentially, it's a supercharged cataract lens that fits inside your eye. It does not, repeat, does not reverse the ravages of macular degeneration. If I tell one of my kids, go out and dig that trench for like irrigation in our yard, and I hand them a shovel, they still have to dig the trench. But it's easier than using your hands. And the IMT is a very specialized shovel. When you put it in the eye, it magnifies things by 2 to 3 times. And the recent studies with over 200 patients have showed that, on average, about 90% of people will have more than 2 lines of visual improvement, and about 25% will have up to 5 lines of visual improvement. Does that make the macular degeneration go away? Nope. But it's easier to use because it's in the eye, it tracks with you. External low vision aids, if you move your eye back and forth, you get into the thinner part or the thicker part of the lens, and distortion and warpage occurs. It's a task. It takes training to do, like somebody having a stroke and then with occupational therapy learning how to walk again or to talk again. It's effort. And with effort and practice comes benefit. The IMT requires that. Preoperatively, before it's placed in the eye, similar to a cataract surgery, people have to be chosen. You have to prove your adaptability in order to receive it. Then it is placed inside the eye surgically, and then post-operatively, it requires a period of adaptation. Why? Because if you have an image that's presented to the brain that's 2 to 3 times larger from this eye, and your other eye has peripheral vision and the image size is the same it's always been, your brain doesn't like that, okay? But our greatest ability as humans is our adaptability. That's why we're all here in the Constitution Center and why the Magna Carta was in 1215 and this is 2010 and we have a democracy and a great 5-page document that's honored in this pavilion. So you have to have realistic expectations, and anybody sitting here who thinks like, oh, I get this in my eye and everything's normal, that's not the way it is. From an outcome standpoint, 5% of people within 4 years had the IMT removed. They didn't like it. 5% at the time of surgery couldn't have it placed in the eye. And 5% of people had less than 2 lines of visual improvement. As a matter of fact, may have had a line or 2 of visual decline. So that's 15 to 20% of people in the total grouping. So the IMT is a tool. It's a very technically advanced shovel. It requires preliminary workup, a surgical procedure to implant it, and post-operative training and care. And it's not perfect. It is just one more step. Thank you.